Good morning and happy Friday. This is WLBT's Ask the Experts, live from the Hub. I'm Kelly Boyd. Joining me today is Dr. Mickey Altree of Ovation Women's Wellness. Glad to have you back, Mickey.
Thank you. Good to be here.
Yes, and so she had lots of good information for everyone on female health care. If you have questions for Mickey while we're live, please ask them, but we have plenty of questions for you from our Ask the Experts page on WLBT.com. And that first question it comes from a lady named Christy. It's a very lengthy, she's given you a lot of details here, so let me get to that one. She says, after a hysterectomy, what would make my lower back hurt like crazy? A back doctor told me to go back to my OBGYN. I called them and they acted like I was wasting their time. It's getting worse and I'm scared that I'll never get this resolved and have to live with this horrible pain. It's so bad I'm left stuck on the couch 5 out of 7 days. I've seen so many doctors and all I get is that it's degenerative disc disease and that I need to see the OBGYN. I sure hope I can get some kind of answer. Can someone please direct me in the right direction? God bless.
Well, certainly, I think the first thing we need to know is pertaining to her hysterectomy. Are the ovaries still in or not? Was the hysterectomy due to having endometriosis, which can cause a lot of pain and those kind of things? It certainly could be degenerative disc disease. That is really disabling to a lot of people. So I hate to say that I'm not answering the question, but I just think it needs to be more evaluated, if that makes sense. So those are the things you need to know. Does she still have her ovaries? Was the hysterectomy due to endometriosis? And exactly how bad is the degenerative disc disease?
So is that something you could look into at Ovation?
We can look into the GYN portion of it. The reasons for the hysterectomy and are the ovaries there, and maybe get a pelvic ultrasound if she needs it. Degenerative disc disease, no, we would refer that out.
Right.
Yeah.
Okay.
Yeah.
All right. Can you explain pH levels in the vagina?
Yeah. So pH levels, what it pertains to is an acid-base balance. I mean, that's what it is. In the vagina, the pH needs to be 3 or below. Now, what that does, the pH itself, what it does is it keeps the good bacteria within the vagina. So, in other words, we have lactobacillus bacteria in the vagina all the time, and you want to keep it in there. You don't want it to be too much. You don't want it to be too little. If it's too much, then we have yeast. And so a lot of women have chronic yeast where it's itching or it's just discharge or whatever. But when it gets too high, you can, with that overgrowth of the lactobacillus, we need to treat that. And not only with things like diflucan or monostat over the counter, things like that.
You see a lot of commercials for those types of things. Is that would you advise going that route, or should they see a doctor first to determine that's the
if
issue?
it just happens every now and then, that's fine. I always tell my ladies, if you're going to do monostat, do the 7-day, not the 3. I just see better coverage if you do it for the whole 7 days versus 3.
Sure.
But now, if the vaginal pH is way too high, then the lactobacillus cannot thrive. That's when we see a lot of recurrent urinary tract infections and those kinds of things. And it's primarily from 2 issues. Number 1, vaginal douching. You should never do that. You just don't need to do that. And then number 2, if your estrogen levels are very, very low, it can't feed the vagina. That's where you get the normal lubrication. But then what the estrogen does is it keeps that vaginal pH at a very low level so that the vaginal mucosa lining is healthy like it should be, and that pH balance is low.
Okay, great. What age should women start getting a colonoscopy?
Number 1, if you've got a strong family history of colorectal disease, you need one certainly very young, I know that some people are doing some genetic testing for that too now to see, if you have the genetic propensity to develop colon cancer. Guidelines are typically that a screening colonoscopy be done at the age of 50. We refer all of our patients out for that. And then according to those findings, the follow-ups are then scheduled. Could it be every 3 years, every 5 years, every 10 years? Really depending upon what they find with that screening colonoscopy.
Okay. You have some fans over here, Dr. Mickey. She says, Jazz Clark says, Dr. Mickey is an angel for women, and I love her so much. I had a hysterectomy when I was young, and she was a true blessing for me. Thank you for helping me. If you haven't been to her office, please go. Her whole office is amazing.
Oh, thank you, Jazz. Thank you.
And Nicole says, I love Dr. Mickey. She has been so wonderful.
Oh, thank you, Nicole.
Helping
thank
people.
You. Thank you.
All right, back to questions from the Ask the Experts page. We've got, what is a bone density test?
So a bone density test is really important for women because when you lose your estrogen as well as your testosterone, testosterone is just as important for bone health as estrogen is, the bones can become very weak. When you have a weakening of those bones or a thinning of those bones, that's called osteopenia. And then when it gets so bad, it's called osteoporosis, meaning that it just continues to thin.
Right.
And that really sets women up for falls, well, hip fractures from a fall, not a fall, but a hip fracture from a fall. And that is actually the number one leading reason why women are admitted in nursing homes. And it all stems back to a fall, and they have osteoporosis, and the bones break. So it's a really non-invasive test. I mean, you literally just lay down, the machine goes, and you're pretty done,
When should we start getting those?
I try to have my women to start getting them at the age of 50. One of the things that you have to think about is any other risk factors that women have for that, such as, are they on high-dose steroids for whatever reason? Are they on thyroid medicine? There's things that can actually potentiate the loss of bone. So, it's a very individualized thing. I try to have women get it at 50 so that we can stay one step ahead of it.
Sure.
And then you want to make sure that you've got enough calcium, you've got enough vitamin D. So those things need to be checked as well. It's not just the bone density itself, so.
Okay. Sheila says, is sudden bloating a sign of something serious?
It's what now?
Sudden bloating.
It certainly could be, especially if you still have your ovaries. The leading sign for ovarian cancer is like a pelvic pressure bloating that never really goes away. Well, it certainly could be GI related. I mean, there's multiple things that could be related, but if it continues, I certainly think you need to seek the advice of a provider.
Or if you try a probiotic and it's not helping, it could definitely be something else.
Right, absolutely. Or a prebiotic. Nowadays you can do both. So, yeah.
Okay, good. And Missy Washington says, what can a woman do for excessive head sweating?
Well, first of all, we do see a lot of that as well, and people just go, I'm having a hot flash, and, typically, I mean, it very well could be. A hot flash tends to start like this intense kind of internal heat generation, and then it literally can just go up, and then your sweat's dripping from your nose. But there is a situation where you just sweat a lot, and so for those women, there is, if we discern that that's what it is, it's just just excessive sweating versus a hot flash, right? Yeah. Then there is a medicine that we can prescribe for that, and it really does help.
Good. So, the things we look forward to.
Yeah.
Okay. What is the average age for perimenopause?
So the literature says that it's typically around 40 to 48, somewhere in there. That's what the literature says. Now, as a female, number one, as someone who went through an early menopause transition kind of phase, I do not put an age limit to it. I just
okay.
do not. I will tell you what, in my opinion, from the time that a girl starts her menstrual cycle, she is in a hormonal transition. Now, I'm not saying that you start your period and you start right into perimenopause or menopause. I'm just saying the hormone levels begin to decline a little bit.
Yeah.
So I say that you can be in a hormonal transition period at any point in time in your life. But again, the literature says that, it's typically the earliest they would recognize it is 42, typically around 46, 48, something like that. But at any point in this transitionary period, you can begin to have symptoms. We now know with hormone therapy, we need to be evaluating the ratio and proportion of one hormone to the other. You don't just say your progesterone is this and so therefore it's adequate. You really have to look at what is the ratio of the estrogen to the progesterone to the testosterone. Okay. So you can be in a hormonal imbalance at any age, really.
Okay. Melissa says, if you've had a hysterectomy in your 40s and you're 65, do you still need to take estrogen and also testosterone, which I've never taken?
So I'm not going to make a blanket statement, Melissa, and say that you definitely need estrogen. There's multiple variables to consider with that. We need to consider any risk factors that you have for estrogen. Those are things like migraine headaches with auras. Do you have any breast cancer history? Have you had a stroke or TIA, like a light stroke? Have you had things like that? And all of those have to be taken into consideration. Also, we were trained that if you have been without hormones, and I believe she's probably been without them now for like 25 years, it's not advised that you just put a woman on estrogen. So in our clinic, we look at the hormone levels, we look at risk factors, we look at different options of how to take those, and then really decide, do you need the estrogen or not? Many, many women do very well with only a testosterone replacement because the body will absorb that testosterone and then convert it over into some estrogen, which you get benefits from in the brain, the bones, the gut, all of those factors. So it's a very individualized thing.
Okay. There, let's see. What is female sexual dysfunction?
Oh, my favorite topic. So I started studying female sexual dysfunction in 2002 when I started working on my doctorate. In 2002, the definition was paragraphs long, and it all looked at different variables that came about with sexual dysfunction, and it was very convoluted. In my simple brain, it was very, very convoluted. To make it simple, we've transitioned through the years, which has now been 17 years, unbelievable, but we've now kind of really cleared it up, and sexual dysfunction is defined as, female sexual dysfunction is defined as a persistent decrease in sexual desire, meaning you think about it, you want to engage in it, a deficiency in the ability to become aroused, an inability or a poor quality orgasm, or pain. So we've really kind of simplified it over the years. It was so broad in 2002. I think that's what kept a lot of women from telling their providers, or even providers even approaching the issue. And so now that we've got it more clear cut, I think that's why we're seeing a lot more women come in and,
from 5 paragraphs to like 5 bullets.
Absolutely. So I believe in kind of keeping it simple. So, and it won't take a provider long to realize that these overlap with each other. And so, you really just got to figure out exactly what is the originating cause. Because a lot of times, if it's pain, well, who's going to want to have sex if it hurts?
Right.
Really? You know? And then, you know, my motto, well, if you're not going to get something out of it, well, I mean, you know? So I think they just overlap with each other, and you really just got to hone in and figure out diagnostically as well as subjectively exactly what's going on.
Okay. All right. Your favorite topic, huh?
My favorite topic, yes, because that's what my doctoral research was in as well. That and how hormones, you know, make it better. So
okay,
yeah.
And you may have answered the next part of that question, but you probably, I'm sure you have more to add. So
oh, you know I do.
I'll go ahead and ask it. Are there different forms of female sexual dysfunction?
Oh yeah. And yeah, I did. I'm sorry, I jumped the gun. So the biggest one that I hear is I have no desire. That's the biggest one I hear. I would venture to say that probably 70-85% of the women, that's their very number one complaint. So they tell me I never think about it. It never enters my mind. Or it is so bad that I make sure that I go to bed way before he goes to bed.
Oh, gosh.
I pretend I'm asleep.
How often do you, hear these things with lots of patients? So?
Oh, yeah.
Oh, wow.
Yeah. Then there's women who tell me, you know, I could think about it all day long, but there's nothing going on down south. You know, I mean, there's not that connection down there. So they'll say, you know, I can think about it. I can even mentally become aroused, whether that's through visual stimulation, manual stimulation, reading, I mean, whatever. But there's just no connection. So then there's women who say, I have no orgasms. I've never had an orgasm. Never in my life. And women who go, I don't think I have. I say to them, no, you haven't then. You know, and you've got to think about it. You know, no, you probably haven't. But then there's those who say, well, not only do I not have it, or, which may be even more frustrating, I can become very sexually aroused. And like riding a roller coaster, you want to go over that first big hump. They never get over that hump, you know. And so that's frustrating in itself as well.
Sure.
Then there's women who say, I do not engage in intercourse because it hurts too bad. Now, whether that's on penile vaginal just entrance, whether it's with deep thrusting, you know, whether it's even with manual stimulation, a lot of women have a lot of pain down there. And so the first thing that they want to do is go and buy a lubricant over the counter because that's what's advertised, you know. But if it is persistent and they are using a lubricant, you really need to come in. That the vaginal tissue, the outer genitalia issue, we really need to look into that and see exactly what's going on.
Okay, good. Let's see. Prevalence. What is
Yeah. When I started studying female sexual dysfunction back in 2002, the literature all said that no more than 43 to 46% of all women, all ages, suffered from some form of female sexual dysfunction. I can so remember sitting there reading that and thought, I'm not the sharpest tool in the shed, but what I can tell you is that close to 85-95% of all women that I asked were complaining of it. Now, I will say that, yay, I was right, because now they've been changing the diagnostic criteria for it, number one. I think number two, healthcare providers may be a little bit more comfortable with talking about it. I think number three, women are more comfortable now to take charge of their health and their quality of life.
They have more information to know that
absolutely
it's not right. You know, something is wrong.
Absolutely,
there, so.
and it's not taboo anymore to
don't just
discuss
accept
it.
it.
Yeah.
Right.
And so now I just looked at the data yesterday afternoon, and now the Mayo Clinic has actually come out and said an average of 22 to 25% of all women under the age of 25, have some form of female sexual dysfunction. That's huge.
Yeah.
Then for the women between the ages of 45 and 65, it's as high as 75%, which totally correlates with what I see in clinic every day. So it is a very, very prevalent problem.
Yeah, wow. Okay. How is female sexual dysfunction evaluated and diagnosed at Ovation?
At Ovation. Now, we do it differently, and that's probably because of my 17-year interest in this, you know. We approach it differently. We diagnose it differently.
Okay.
Now, most of the time in healthcare, a woman walks in and says, it's one of those, oh, by the way, when the doctor's walking out of the room, or the provider, oh, by the way. Oh, can I just tell you I'm having a little bit of sexual dysfunction, you know? So typically it's diagnosed with, oh, okay, well, you know, all of the research, or I wouldn't say all, the primary research says that the brain is the biggest sex organ for a woman. I will not negate that. I will not. But there's multiple other factors that go into it. And so typically the first forms of therapy is a medicine called Addie, which is FDA approved. And it is for hyposexual desire disorder, meaning that you don't want to engage in intercourse or you don't think about it. So it's all geared toward the brain. Or it's, well, drink a little wine before you want to engage. Or think about, I was actually told in the dark ages, well, just think about an actor that you think is very good looking. Drink a little wine, think about an actor, and you got it, you know. And so typically that's how it's diagnosed. Now, at Ovation, because of my interest, I look at it totally different. I think there's multiple variables that goes into really good sex for a woman, and I think that it is a psychosocial issue. I think women, we are very multitaskers, so we can go to bed at night with a load of laundry in the wash, a load of laundry in the dryer. You know, you forgot to load the dishwasher. Oh my goodness, I have nothing to cook for breakfast in the morning for the kids. You know, so I think we have to look at that. And we actually do encourage women to literally take time out of your day, make yourself think about it, prioritize, you know, the day's events so that you can really focus on that.
Put a reminder in your phone.
Absolutely. If that's what you have to do, that's what you have to do. Because I do think there is such a brain element into it. You know, have a date night. So many things that you can do for that. Then there is the psychosocial issues of weight gain. Oh my goodness, I'm looking older. You know, all of a sudden you look in the mirror. I mean, I'm 59, and all of a sudden I look in the mirror and things have fallen.
This is not the same body.
Crooked. And oh my goodness, you know. And so then that self-perception really comes into play. So I do think those things need to be considered and discussed. But one of the biggest heart-wrenching things that I hear is I always ask women, have you ever been a victim of rape, incest, or molestation? And it absolutely breaks my heart when they begin to cry and say, I am 50, 45, 60 years old. No one has ever asked me that question before. So I think I can take care of all the other parts. I can get the hormones good. I can get your vagina healthy. But with that issue, we really need to seek professional help for that. I have, in the 9 years I've lived in Mississippi, I have really developed a lot of relationship with some psychiatrists and some psychotherapists who have just done wonders for my women. So I tell them all the time, look, let's let that professional work on this while I get everything else healthy. So definitely I think the psychosocial issue is very important. We look at an endocrine dysfunction. The data for women, and when you start to really break it apart and look at it and diagnose it. In 2002, the analogy that they gave us was sexual functioning for a man is like a light switch. It's on or it's off.
Uh-huh.
Comparatively to a woman, it's like the cockpit of a jetliner with all the multiple variables that go into it, you know. And I truly believe that, but now that we have decreased the definition of it, and we've actually begun to, providers all do it a little differently. That's why we call it the practice of medicine, you know. But providers like me who have really broken it down into the multiple variables that it could be, I think that that's helped. So we've taken that cockpit and we've taken 4 of those dials out and combined it to the psychosocial issue, okay? Then another dial is the endocrine aspect. So now we know that estrogen, testosterone for women, and progesterone have a definite play in hormones. With the research that I was able to be a part of, one of the things we saw is that testosterone helps to really curb the frontal lobe. The frontal lobe in the brain is where we lose our inhibitions. So testosterone really feeds that. So you have to have a certain level of testosterone.
Okay.
Then for that testosterone in the frontal lobe to connect with the nervous system, you've got to have a good estrogen component. The estrogen therefore gets the signal down. It goes down the spinal cord, through the pudendal nerve, into the vaginal vault, where now you begin to have moisture, and the clitoris, where now you have more estrogen feeding that clitoris, and so you have better nerve response from that.
Okay.
The third aspect that we look at Ovation is the neurological aspect of it. Now that goes right back to me talking about the estrogen component and that kind of thing. So with things like any pelvic organ trauma, that includes vaginal birth babies, you can literally lose the nerve innervations that feed not only the G-spot, which is real, even though we've been told for years it's not, it is real. But you can also lose the nerve conduction and the good impulse formation from the clitoris.
Okay.
We have diagnostic testing that we can, at Ovation, where we can literally discern, is it clitoral in origin? Is it vaginal in origin? Is it the G-spot in origin?
What's the real word for G in G-spot?
Graphs.
It's a long one.
Grafton, G-R-A-F-F. That's the only part I can remember it.
Yeah.
But
that's why it's been called the G-spot.
That's true. Yeah, because nobody can remember it.
I think the next time you come, we should have a whole episode about that.
Absolutely. I'm up on it. And then, you know, the fourth aspect that we really hone in and diagnose is just the physiological aspect. Now, what I'm talking about there, I'm talking about the physiology of the vagina. So we look at the clitoris, we look at the labia, we look at inside the vaginal vault, the opening to the vaginal vault, all of those things, discerning, do we need to do a biopsy? Is it a lesion that's growing? Is it simply that estrogen could really, an estrogen cream could do it? Meaning, you know, take care of the problem.
Right.
We take all 4 of those aspects and put together a plan that's individualized for that person.
Okay.
Then women say, well, there's absolutely nothing that can be done about it. You know, multiple providers have told me, you can't treat that. You know, no, that's wrong. You certainly can. If it is a hormonal issue and we can individualize it where you're getting the lowest dose with the greatest benefit, then let's do it, you know. If it is women like who've had breast cancer with chemotherapy, radiation therapy, they can't have any hormones whatsoever, and we wouldn't give that to them, you know, or women who we get their hormones better, but they're still not where they want to be. There's things we can do, thank goodness. We don't have a female Viagra. Women do not have that. So science has actually taken a different curve with that. We can do things for orgasms, what's called the O shot, orgasm.
It's actual shot.
It's an actual shot. And it sounds horrible, but I can tell you it doesn't hurt. I won't say how I know it doesn't hurt, but I can say it does not hurt, you know. So basically what we do is we draw your blood out of your arm, you as the patient. We put it in a special tube, you spin it down in a centrifuge, and you draw off your own plasma-rich protein. Now that's really been a new eye-opening demeanor for medicine in general. We're using plasma-rich protein for so many different things. Well, why not put it in the vagina and the clitoris? You draw that off, so I'm actually putting you back in you. It's nothing foreign at all, okay?
Okay.
Now, this is the part where women are going to go, oh my God. I can tell you, we numb up your clitoris. We numb up where your G-spot.
So that's where you get the shot.
That's where you get the shot. We numb up where the G-spot used to be, or where you may still have it. It just needs a little extra sensation going on, you know. And we inject it directly on the side of your clitoris.
Say it doesn't hurt.
And your G-spot. I mean, you'll kind of go, but believe me, it's worth it. Well, what happens then is that those plasma-rich protein, over the course of an average of about 3 to 4 weeks, you have a release of your own human growth hormone. When you have a release of your own human growth hormone in the clitoris and where the G-spot used to be, still is, whatever, it causes a rejuvenation of nerve endings. So not only do you have more neurological nerve endings down there to be stimulated, but it also kind of bulks up the tissues a little bit in the vagina. And so it can help increase the sensation on the man's end as well as the woman's, because you kind of got, I don't mean to be gross, you got a bigger target to hit.
Okay.
You know, inadvertently, the O shot not only helps with orgasms, clitoral and vaginal thrusting orgasms, but it also helps with urinary incontinence.
Oh, well, that's great.
So, you know, you kind of get your cake and eat it too,
Definitely.
you know? And it's all because it just kind of bulks up under the urethra, which is where the urine comes out, and so it just gives it a little bit more stability.
Now, is that part of vaginal rejuvenation? Because you mentioned the word rejuvenation, and it sounds like there's benefits of it there, but is that part of it?
It's part of it.
Okay.
It is definitely part of it. And that, thank you for mentioning that, because then that brings me into the other vaginal rejuvenation things we can do. We do a procedure called Mona Lisa Touch. I hate that name, but you know, she didn't look like a happy woman to me. But the Mona Lisa
Has she been to Ovation?
That's right. There you go. There you go. And maybe she has sexual dysfunction, right? So, but the Mona Lisa Touch, it uses laser therapy. Again, it doesn't hurt. I can tell you, it doesn't hurt.
Okay.
And it uses laser therapy. So what we do, we put the woman up in stirrups like usual, you know, for a pap smear or pelvic exam. The sensor probe we put inside the vagina, it's not really big, it's cold and it's hard. It's basically, I mean, from that sensor, we emit laser therapy, okay? Now what the laser does is it punctuates the vagina mucosa, which signals to your brain that you've had some form of injury. And so the brain pushes collagen down into the vaginal vault. So that thickens up the tissue. So now women have less pain because it literally kind of covers the nerve endings or whatever. It just kind of thickens up the tissue.
Yeah.
With collagen comes natural vaginal lubrication. And so we have improvement in not only the lubrication, but also any pain elements that they have.
Sure.
Another procedure that we can do if it's needed, it's not to say that women need all of this. I'm not saying that at all. And that's the thing that we do at Ovation, is that we really diagnose exactly what do we need to do. Really, what do we need to do? The other procedure is called a ThermaV. And the ThermaV uses heat, which again, this doesn't cause any pain. And the heat inside the vagina actually bulks up the tissue. And so now the vagina feels stronger, it feels tighter, and women get more benefit, that way.
Right.
Another thing that I do with all of my patients is teach women how to correctly do a Kegel exercise.
We talked about that last time.
Right, and I don't even call it Kegel exercises anymore, because women just go, yeah, right, whatever. But if you're taught to do them right, and you're put on an exercise program that is specifically individualized for you and the strength you already have in that muscle, it helps the intensity and quality of orgasms, number one.
Sure.
Because that's the muscle that's contracting like this when a woman has her orgasms. It also can help with urinary incontinence, whether that's cough, laugh, sneeze, leak, or I gotta go, So we really look at multiple variables with that.
Okay.
The other thing I don't think I really expanded
This
on. This
question's getting a very detailed response, so I hope that they tuned in for their answer.
Me too. When you look at the vaginal tissues, you have to really discern exactly what's going on. We do a lot of what's called vulvoscopies in our clinic, if it's needed. And a vulvoscopy is literally where, just through some special magnified equipment that I have, I can actually really look almost microscopically at the tissue on the outside of the vagina, at the labia, and discern, does this tissue not look in color, in character, in size that it needs to look, and we can biopsy to see if a woman has something like lichen sclerosis. Lichen sclerosis goes really underdiagnosed all over, in all parts of the United States, because providers tend to assume, okay, well, it's just dry tissues and things like that. So there's there is specific therapy that you do for that, so that you can get it at bay. Most of the time, if a woman has lichen sclerosis, you can't cure it, but you can certainly get it very tolerable so that they don't have a lot of pain sensations.
Okay, great. And we are running out of time here. I think you actually answered, you were talked about therapeutic interventions in your response to that question, didn't you?
Yeah,
Did you miss anything on that?
Oh, yeah, I talk a lot, so I don't know. I just want to hone in again on that it's multifactorial. So we need to look at hormones, we need to look at tissue, we need to look at the psychosocial issues. I mean, we really need to get an adequate diagnosis, in my opinion, for female sexual dysfunction, and to really steer toward your therapy where you get the biggest bang for your buck.
Yeah.
You need to look at all those variables.
And you mentioned, oh, by the way moment is what you called it a little while ago, when they kind of tell you something at the end. I know clinicians and therapists who have said the same thing about their clients. Whenever their appointment is over, they say they will drop a bomb right at the end of the appointment.
It always starts with, oh, by the way.
Yeah, and it's like, oh, you should have started the appointment with that, because, it would have, really been answered probably by then.
Yeah.
So don't be afraid to tell your provider what's going on in the very beginning. And if something's still not right, see Mickey at Ovation.
Thank you.
I wanted to try to squeeze in. I think we have just a minute. Can you answer her question quickly? Probably. Probably has lots of details. But Karen asks, and we can get back to, we can type her question if we need to, her answer. I have no hormones and no sex drive. I'm 56. What do I do?
Well, you get evaluated. I didn't mean that to sound curt, but
Sure.
You do. if you can't have hormones, there are some things over the counter you can try. I don't recommend the KY, you know, coming out of the water commercials.
Oh, yeah.
You know what I'm talking
We
about?
talked about that last time, too.
Yeah, I don't recommend that until we know that the vaginal mucosa is healthy, that the pH is in the right balance. But there are some creams that you can apply around the clitoris and things that women have said really helps, you know, with sexual dysfunction. I would want to evaluate her thoroughly to see can she have hormones and what other factors are going on.
Because there's going to be some individualized things needed. Okay, so hopefully that's a start to your answer there, Karen. Mickey, or one of her colleagues, I guess, will be back with us, Ovation's Women Wellness, next month, September 27th. Thank you for giving everyone your expertise today.
Thank you. Thank you.
And thank you all for your questions. On Monday, we'll talk about breast cancer with Dr. Sugg from Baptist Cancer Center. They're switching to cancer. They've been doing heart with us, so we'll be talking cancer on Monday. So send your questions to the Ask the Experts page on WLVT.com. Thank you for watching. Thank you for your questions. You have a wonderful weekend.